Hi, welcome to Detours, Understanding Acquired Brain Injury. We're going to be talking about making sense of CT scans or CAT scans. CAT stands for Computer Axial Tomography. Now we've shortened it to computer tomography because the fact that it spins around the axis of the body really doesn't matter. We know that. We know these things spin, and the new ones don't actually do as much spinning as they used to because the computer uses its own interpretations, and the x-ray sources are located around the patient, so it's more sliding in and out. But the original ones relied, because of the slowness of the computers, a lot more on movement of the x-ray source. But let's get into that. We're going to talk about the earlier, more primitive methods of imaging the brain because there were a number of ways they could image the brain, but the problem was most of these were more primitive, and so they were painful generally and provided very little useful information. You had to rely on a good clinical exam and a lot of doctor's skill in interpreting these. The radiologist had to be skilled, and so did the neurologist or neurosurgeon usually, because by the time they had figured out that you had a brain bleed or swelling, they were going to be operating, because quite often mortality was very high and there really wasn't much to do, which is why there hasn't been much development in neurosurgery or in neurorehabilitation with biologists, neurorehabilitation, until recently, because most patients died, and only recently has imaging become a significant thing. We're going to get into use of the MRI and talking about its technology. We're going to be talking about PET scans and SPECT imaging, which are more functional than anatomical. The CAT scan or CT scan and the MRI are more about surveying the anatomy and making quick decisions as to whether surgery is necessary or what kind of lasting damage has been done. Whereas the PET scan and the SPECT scan is more about how the brain itself is functioning, how the different areas are working together. So let's get started then. All right, before the CT scanner, there were a couple different techniques that were available. As you can see in the image here, this is from what's called a pneumoencephalogram. And a pneumoencephalogram involved a regular x-ray machine, some high-resolution film, and what they would do is in the patient, they would perform a lumbar puncture, and then they would draw out about 6 milliliters of fluid, cerebrospinal fluid, and they would then inject through a filter air. They would take compressed air and they would slowly put it into your cerebrospinal fluid, and then they would literally use a special tilting chair to get that bubble to travel up. Now, fortunately, unlike your circulation, it wouldn't risk causing cardiac arrest or anything like that, but it would cause a wicked headache afterward. And they generally didn't take the air out. You filter through the choroid plexus in your brain, and it would eventually work its way out. However, it did help with the imaging to a degree. They were still poor images, but you could see the ventricles, you could see if the sulci, which are the folds in the brain, had become wider, or you could see if there was a bleed. And so it was useful, but it wasn't a very comfortable technique, and if you had a critical patient, you really couldn't do this. So instead you did the next thing, which was the echoencephalogram. The echoencephalogram relied on using sonar technology. They would bounce the signal off your ventricles, off the lateral ventricles located in the middle of your head, and if the ventricles had moved to the left or to the right, they knew you were bleeding inside your head, and based on the oscilloscope image, which was just a simple line, and if that tracked off the center line, they knew that they had to do immediate neurosurgery. Again, it wasn't a great technique. It was poor, low resolution, but it's what they had. Finally, x-rays and exploratory neurosurgery. The very simplest one were x-rays, which goes back to the 1890s. And they had used it since then to see if there was a crack in the skull or to see if something was displaced, and that would tell them, hey, maybe it's time to perform exploratory neurosurgery, where they would literally just drill into the skull and see if something came out, if there was blood that gushed out, or if the brain matter was literally bulging and swelling. Well, there's your problem. So you needed to just take out that piece of skull. Problem is, obviously, often there was a lot of fatality because you'd have infection, there wasn't the controls, and so obviously a different solution was necessary. And so Sir Godfrey Hounsonfeld, I'm not sure if I'm pronouncing that right, a British engineer for the company EMI, developed the first CAT scanner. He figured out that he could use an equation from the 1850s to build a three-dimensional image by turning around the circumference of the patient and by sliding them in on a table as they were put inside the machine, that he could build a three-dimensional voxel, which instead of being a pixel is a three-dimensional image. You'll hear the term voxel other times, but a three-dimensional section or slice of the patient, and could use that to construct an image. And so he was the first commercial developer and seller through EMI of the first CAT scanners to hospitals, starting 1972, when I was born, so a long time ago. All right, so here you see in this image the different ways that a CAT scanner can image. On the left, you see the traditional older style, which is where you literally would just move the X-ray scanner back and forth around the patient, and you would, as you slid the patient inside the machine, the detectors would pick up the X-ray radiation and they would build that image. The computer would use that to construct the image. Now, the modern ones use multiple low-energy X-ray sources, and so the receivers, which are all over the patient, and you just have to move the receivers a tiny amount. You'll hear the spinning sound as the X-ray guns are moved, but they don't have to move as much. And most of the movement that's taking place is the table you're laying on as you slide in there, and a couple quick snaps, if you will, and you've got the image completed in 30 seconds with the new high-speed X-ray imaging for these new CT scanners, because it's multiple beams. The computer knows which ones it's from, and by extracting certain images from specific beams, the computer can even slice up the patient in much smaller slices, and they can even do movement. They're fast enough now that they can look at the heart while it beats and capture it between beats, like make a small film and see its performance. But for the brain, we're more interested in a static image. We may want to look to see if there's pulsations in blood vessels and things, and that's where using contrast dye of iodine comes in. We'll get to that later. All right, so the basic layout of a CT scanner is pretty simple. They've gotten small enough to even fit in an ambulance now, but as you can see here, they're pretty universal. It's not a very large machine. They used to be much bigger when you had to cool them a lot more because of the X-rays, the single X-ray source and all the moving parts. Now that they're pretty stationary, the X-ray guns are fairly stationary, just back and forth. You don't have to cool them as much, and much more advanced receivers. They're basically a CCD camera, the receivers, except they're tuned to a different frequency. Remember, X-ray is still light, and so a CCD camera can pick it. The major difference is that it has to be resistant to the penetrating nature of X-rays, and the patient lays on the table and they're put through really quickly, and so that's what you see here is a simple diagram of a modern CT scanner. All right. One thing that's important before we get into this is understanding that when you're looking at a brain, you're going to slice it in effect, and the computer does a certain form of slicing, so you could see the brain from different three-dimensional perspectives. Remember how I said the voxels, the pixels that are three-dimensional, allow you to look at the brain from different angles. And there are three main ways to look at the brain. You can look at it frontally, which when you're doing that, you'll be looking at the brain head on, and you slice it like a loaf of bread, and you can look at different depths as you traverse it back. And there are specialized software packages that allow you to, in effect, to rotate it. And so you can look in different areas of the brain as a physician or as the radiologist. You can look at it and say, all right, there's swelling in this area, there's a tumor, and you can even extract a tumor electronically and rotate it and look just at that object. You also can look at certain areas, like if you wish to look at the cerebellum, in which case you would be doing what's called the sagittal plane, and that is looking at it as though you slice the brain in half, right down the middle. And the sagittal plane is the most common way of taking a CT scan or an MRI. You will be looking at it on the side, but you'll be taking away, in effect, part of it. And again, that's done as the X-ray gun spins around and the image is captured it'll ignore part of that image and project, and you could slice out the brain to different thicknesses and look in different areas to see bleeds or to see swelling, things like that. And finally, the transverse plane is looking down from the top down towards the bottom. Again, not as common, but for certain problems, they may wish to do that, the transverse plane, which is slicing in this direction. Again, all these manipulations done by the computer, and as computers have gotten faster, they provide different ways of looking into the skull. All right, the first one is a pretty simple image that, if you're looking at your own images, you want to look for skull fracture. Did you have a skull fracture? Because that's a lot of energy. It takes a lot of energy in a trauma to fracture your skull. Picture on the left shows skull fracture, and you can obviously see in the upper left quadrant, skull fracture. All right, next is cerebral edema. Skull fractures are common, but not necessary. Even in a great amount of brain traumas, you won't see that as often. This you will see a lot. Cerebral edema, which is swelling, which is where the parenchyma, the tissue of the brain, swells up and squeezes itself within inside the skull. This is cerebral edema ongoing. So after a couple of hours, and the brain begins to squeeze itself, and it destroys tissue over time, because not only is blood supply cut off, it just kills neurons outright. And most brain injuries include some cerebral edema. The one I suffered included some of this. There are two ways to solve it. One is watchful waiting, where you scan the patient again and again and watch what happens. The other one is you can remove a piece of the skull. So if they took a chunk of your skull out, most likely one of two things happened. Either you had extreme cerebral edema, or you had bleeding in your skull. Most likely it was cerebral edema, but they do also obviously use it for bleeding. If you had cerebral edema, this is what it most likely looked like. And most patients with this suffer a broad-ranging brain injury, and it includes people with not just trauma, but with cardiac arrest, they'll see this, with infections of the brain, sepsis included, meningitis, encephalitis, and this is what it looks like. As you can see, it's not a high-resolution image, but it does show it well enough to say, and you can see that the ventricles are very squished, and that's because pressure's up. This person will probably suffer serious memory deficits, long-term and short-term, because of how you could see that the ventricles, those dark areas, the long dark lines, are very squeezed tight, and how the brain is swollen there. So cerebral edema is a very important thing you can see on CT scanners. And one thing I want to mention is the things you see on CT scanners it's not going to show you long-term effects other than things you can like imply. That's for MRIs or things you'll see on the MRI, but emergencies, stuff you need to take care of right away. Cerebral edema being one of those things. All right, this is midline shift, which is cerebral edema but usually that's a bleed that will cause a midline shift, and you can see that on the images on the right, where the ventricles have been displaced. They have been pushed aside after 24 hours and after 72 hours. They have been displaced to the side, and you can see how they're no longer in line neatly right down the middle. That is something that would look, if you were to see the brain from the top, you could tell that, oops, yeah, that's always kind of fun trying to put these back together, but you could tell that the way the skull is lined up, yeah, I'm not very good at this, but you could tell how everything's pushed over, and you can see how the ventricles are displaced. So when they're talking about midline shift, what they mean is the entire cerebral hemisphere has been displaced to a side, left or right. And when you see that kind of shift, what it's telling you is that the entire hemisphere of that side is under high pressure, and it's likely to kill a lot of neurons, both deep inside the brain as well as on the cortex and the surface. So they're likely to suffer a lot of neurological symptoms in the long run. And you can see from baseline images here that they show, patient A, B, and C, that there is a lot of tissue that's been affected long term, and that's on the left side there. But you can see how, and the image which is next to it, which shows the peak phase of the venous phase, which is venous drainage. There's the curve too. So these are things to keep an eye on for midline shift, which can be very problematic. So if you look at your own images, if you see that that line is curved or bowing, that means that you are having a lot of pressure within your own skull. Again, CT images not as great for this, but it certainly does alert you. And you can also see there's a lot of blood, the dark areas, that there's an accumulation of a lot of blood. Blood will show dark, much darker than the surrounding gray areas, which are more permeable to x-rays. The dark stuff is blood and is absorbing the x-rays. It's more fluid. And then the white is skull, because that's how they have it set. Okay. Enlarged ventricles, there you go. That's the black areas that are really big. They're like that because all the brain tissue, the parenchyma, the brain tissue is dead around that in the deep areas of the brain. Problem with this is it suggests death of white matter, diffuse axonal injury. We talked about diffuse axonal injury quite a bit. And this tissue that's been destroyed means that this person will have broad-ranging brain injury. They'll have trouble thinking and planning, and throughout their entire brain they will have problems. And they would be a candidate for a shunt. You could see the various white areas that stand out as contrast. That's calcifications. Those calcifications it means this has been an image that's taken a while, but those are dense areas that absorb the x-rays more thoroughly, like skull. And so it tells you this image is older. And so this person's had this for a while. And so they've been living with disability for a while. Now, you can't always see calcifications. It depends on the quality of your CT scanner, and it depends on, whether we have it set for this. But again, you can see that there are these calcified spots, missing brain tissue. It tells you old image, been a while, many years probably. And so this person has lived with disability for many years. All right, finally, this is encephalomalacia. You could tell that because you could see all the little white spaces there, areas where there's no brain tissue left. The sulci, which are the folds there in the brain, those have opened up, and there's a lot of brain tissue that's now missing in those areas. This patient has a lot of frontal. You can see towards the top of the image a lot of frontal damage, and right down the line there, as well as throughout the rest of their brain. Again, you can see small calcifications not too far away from the ventricles. This is an old injury, and it's even spread to the insula, and you can see that by various white patches on the right side of the image. By the way, most CT scans are flipped, so the right is left and the left is right, just like a standard x-ray. But they'll often have a letter attached, or they'll have painted it in electronically to tell you that the image is inverted. And I don't see that here, so difficult to say, but you can see there's a lot of tissue destruction. This is diffuse axonal injury. You can see that here, especially in the frontal lobe. And so those white spots, those white patches stand out much more clearly, and this is in this patient's frontal lobe, most likely right frontal lobe, and it travels all the way down to mid-thickness, and it's into the insula. We talked about the insula in our short video about patient awareness of deficits. This patient most likely would have problems being aware that they have disabilities, and there's extensive tissue loss both in the right and the left side. So this tells you, again, this is an older injury. You see here the brain tumor on the scanner. They've enlarged and enhanced it for you so you can see it, and with and without contrast. Iodine, again, when they start an IV on you, if you have an allergy to iodine or shellfish, let them know, because contrast is based on iodine warmed quite often, just to enhance absorption. But you could see there's the brain tumor. It stands out differently because it is more it absorbs more x-rays, and therefore what comes out of the machine is less. So you can see on the CT scanner, and they also have some tissue shrinkage generally, but those areas that are targeted in the yellow box, you can see those stand out, and that tissue there is small calcifications, as well as they've already placed their small radioactive source to begin treatment. Okay, and this is a CT scan of the cervical spine. You can see clearly both the internal aspect of the the spine, the vertebral bodies, as well as external aspects there. And you can see where the skin is. And what's important to keep in mind here is many people who suffer traumatic brain injury also suffer from cervical spinal injury. C1 through C7 are most common. And at the very top, you can see the C1s, you can see the C1 right here. Right up here, C1, and if that is fractured, or C2, it usually called the hangman's fracture. That typically means pretty immediate death. Not always, but you can end up with an internal decapitation, what it's called, and which is where the nerve cord is severed and those bones are broken, and a pretty quick death, but not always. Some people do survive it if it is stabilized using internal hardware. If you suffer a fracture in these areas, and you can even see the fracture here that this patient has, if this is damaged, if the nerve cord is injured here, paralysis, obviously, depending on how, some forms of hemiplegia could be caused due to like half the cord or the front, the anterior or posterior aspect of the cord is damaged. By the way, gray matter and white matter are reversed in your nerve cord. So white matter is on the outside, gray matter on the inside. So it's backwards. However, if your cord is pinched and fluid, cerebrospinal fluid cannot drain, then you may experience an increased likelihood of headaches due to elevated intracranial pressure. Those headaches are very nasty due to trouble with draining your ICP. It also can affect your cerebral circulation, increase your risk of stroke, and it also can exacerbate risks of migraine and cerebrovascular or craniovascular headaches also due to interference with blood flow. And finally, you also can get increased likelihood of tension headaches too, due to effects on that on the nerves that pass through and up into your head and through your skin as well. So a lot of headaches can be affected by damage to the cervical spine. And again, a large number of people end up both paralyzed and with a traumatic brain injury. All right, this shows placement of a shunt. You can see the shunt here. And the purpose of a shunt is to drain when you have a blocked ventricle. The blocked ventricle is a problem because obviously it can lead to increased swelling, as you see over here on this side, and destruction of parenchyma. Now in this case, this person already has gray and white matter damage, but at least you've reduced the likelihood of it increasing. This is something else you can see on the CT scan. The important thing to understand is you're still kind of limited to what you can see in a CT image. For as good as they are and useful as they are, they're good for finding things that are emergent. You can follow up with a patient, and many doctors' offices have small CT scanners and things like that, but there are a lot of limits. And so we're going to have to turn to the MRI, which is probably one of the most useful tools that we have, because the CT imager is great for bone and looking for swelling, bleeding, those kind of things. But truth be told, it's the MRI that makes the best images anatomically and can look at the differences between diseases and disorders and can see what really is affecting your health. The problem is the MRI is slower, and we'll be getting into why later on. But just understand that the CT scanner is the best at seeing things quickly in an emergency situation, but it won't tell you everything. And what it does tell you can sometimes leave you asking, what am I looking here? If I need to cut, CT scan is great and at least points you in the right direction. But if I'm looking for detail, neurophysiology, high levels of resolution, CT scan is not your choice, and it won't show you why you're having problems speaking or why you're having trouble, with spelling or thinking or any of those things, unless it is due to an acute emergency problem that can be fixed right away. If it's something more subtle, then you need to turn to the MRI or even the SPECT or to the PET scan. Finally, last image here is a CT scan using contrast and a cerebral perfusion study. And this is where they literally will inject the iodine or some other marker. And yes, they have other markers they can choose from. And it produces these types of images where the software package colors based on the density of blood flow. And so a cerebral perfusion study is good to see whether a stroke may be ischemic or whether the stroke is a bleeding stroke where you need a neurosurgeon. But if it's ischemic, that is, the blood flow is blocked, then you can give drugs, or you can take them to the neurocerebral labs, or any other neurophysiology labs, or take them to see a neuroradiologist who can pull the stroke using the appropriate devices and fix them within a couple hours. But these studies are important again because this is an emergency. An ischemic stroke is an emergency versus a hemorrhagic stroke. About 15% of patients have an aneurysm that ruptures or is bleeding to their head. You need to know whether you need to operate right away or whether it can be fixed with medications, or whether you need to take them to the neurointerventionist's lab and whether they can pull it. And this helps you do that.